I know.
Okay, here we go.
The thing around me, so you're not. Update to continue. We're going, we're updating.
Okay, that's okay. Okay, that's okay.
Yeah.
Hey there. Okay, let's see what we have. There was something that, let's see, let's go ahead. I'm gonna go ahead and do that. Lindsay will be on in just a second. Her computer decided to update.
Yeah. Great.
And so Jennifer, one of the people that's working with me, was at the library, and somehow I guess we didn't get everything squared away, and this is just going to be online. They're not going to have the live audience there, which is okay.
Okay.
That's not going to make a difference for us, but it's kind of weird in that we'd been working on this for 4 months, so somehow something got crossways. Okay.
Hey, Anne, I'm situating people. We had talked about it being broadcasted at Lafarge. It sounds like Jennifer went to the South Side branch also, which
Uh-huh.
was not a space we had. We don't have that space. So I'm not sure where the miscommunication is, but yeah, we don't have the staff or the space right now. I'm sorry, but we do have a lot of interest, and we've been promoting this online opportunity.
Yeah, yeah, we just got, just miscommunication as far as what was going to be, who's on first or whatever. It doesn't really matter. I mean, we're used to doing these things online, and just if we could, we'll just talk about it, what we want to do as far as April, if you've got that capability. I think we'll just talk about it later. Right now, we're just going to go ahead and get going with this. Cool.
I don't know how to unmute Lindsay. I admitted her to.
I'm going to make her a co-host. There we go. And she'll be able to then unmute herself back and forth.
Okay, now we should be good.
There we go. And I'll just be moderating, obviously, and we'll keep people muted as they come in. And I'll do the slides. Obviously, we are having daycare as well. Lucas is going to have fun.
He's so cute.
I
It's been
know.
months since I've seen him.
So it's really great. Yeah, it's wonderful. So I think this is the second time we've done this one, right, Lindsay? But we do like our fall prevention every quarter, and it's really fun. So I'm going to go ahead and start admitting people, and I'll just go ahead and share the screen. Hold on a second. Record. No, that's not what I want. Hold on. I'll just stop sharing to start again. There we go. There we go. Participants, I'm going to go ahead. I've got people in the waiting room, so there we go. Lindsay, you're able to unmute yourself, right?
Yes, I am.
Great. All right, perfect. All right. Admit all. There we go. I do have this on record, I believe. Yes. All right. I'm going to go ahead and okay. Oh, okay, let's see. Hey, Marie, your mom's trying to sign in. There we go. I don't know if I can send her an invite right away. So good morning, everybody. We'll get started shortly, but meanwhile, we'll be admitting everybody to the workshop. This is Emergency Department or Urgent Care. And my name is Ann Church. I'm the founder of Villages of Santa Fe. Our program is keeping our older generation happy and healthy. And it's not just a goal of Villages, it's our unwavering mission. Since 2016, we've presented programs tailored to our older population. And our commitment goes beyond activities. It's about creating a healthier, more resilient, and deeply engaged individuals and empowering us to live fuller and more active lives. You can check out our programs online. We offer a variety of exercise programs, including 3 free classes a week. Our wellness programs are free, like today, as well as a number of our exercise programs. And our wellness programs are specifically designed to help you understand how to get the most from your healthcare provider, how to be proactive about your health and understanding your rights, but also how to have compassion for those providing the services. Understand what you can do to make your medical experiences better with a more productive outcome. So, navigating our medical system is at the very least hard, but in an emergency, it can be more terrifying, and information is important. We're recording this session, so it'll be available on our website tomorrow afternoon at www.villagesofsantafe.org. We'll keep you muted during the session, and if you don't wish to be recorded, please turn off your video. We do have a number of events coming up, and we'll get to that shortly. Our presenters today are Dr. Lindsay Ballard and Dr. Marie Hennelly, and we're really grateful for them to spend the time, having them spend the time with us. Again, if you'll please remain muted during the presentation, but if you have questions, please put them in the chat. But we're not here to answer medical questions, just questions about our topic today. Again, Villages offers a wide variety of programs, 12 programs, exercise programs weekly, and 3 of them free. So you're welcome to join us at any time. Coming up in April, we have 2 really wonderful programs to discuss how you would like your life to be. We have end-of-life options in New Mexico on April 8th, and also the Advanced Healthcare Planning and Directives on April 22nd. You can sign up for those free online, and we would be glad to have you join us. They'll also be on the library calendar as well. So today our program is Emergency Department versus Urgent Care. And the reason we present this because when you are trying to make that decision, you fall, you hit your head, you wake up in the middle of the night with pain, your child spikes a fever. We're faced with the uncertainty of where to go for care. And while the answer is sometimes straightforward, being informed with what levels of care are offered at urgent care or emergency department can help you make quicker and better decisions in that emergency. Today's information can help you understand what you can personally do to make better medical decisions, how to be proactive about your health while understanding your rights, and having compassion for the healthcare providers because they have really stressful jobs at that point as well. So we want this all to lead to a more productive outcome should you have to go to the emergency department or the urgent care. So our presenters today are two doctors, Dr. Marie Hennelly and Dr. Lindsay Ballard. And Dr. Marie Hennelly is a bilingual bicultural board certified family medicine physician from Santa Fe with a focus on pediatrics, obstetrics, and addiction medicine. Dr. Lindsay Ballard is a board certified emergency medical physician with emergency medicine specialists and a board certified hyperbaric and wound care physician at Providence Portland Medical Center. And full disclosure, these two doctors we've known each other since everybody was in grade school. Our families are good friends. And Dr. Ballard is my daughter. And as you see, probably in you might see my grandson. So, we're doing a little bit of multitasking here. So if you have questions, we're just going to keep you muted during the presentation, but you can put your questions into chat, English and or Spanish, doesn't matter, but just no personal medical questions, please. And again, this is, they're here as individuals. The personal views are given today are not representing their institutions, and it's not medical advice. So please just take this for information for making things easier to navigate the medical situation. So Lindsay, Dr. Ballard, would you like to take over about the emergency, when to go to the emergency department?
Sure. Yeah, good morning. I do apologize if my son mutes us or otherwise, interrupts. So, I guess the short of it would be that honestly, we can take care of almost everything in the emergency department, but there might be better uses of your time if you're able to go elsewhere. It just depends on the situation. But our staff is comprised usually of doctors. Sometimes there are some other people there like NPs or PAs. You might have heard those terms. And then obviously we have nurses, we have technicians, we've got housekeepers, we have all kinds of other people kind of working in the background to keep the process moving. We also have the ability to call a bunch of other doctors, which is not always the case some other places. So we usually have other people hanging around like surgeons, cardiologists. Those are just some of the specialists, subspecialists that we have over there. So certainly we're there for emergencies. We certainly see many non-emergencies, but we're happy to try to get to everybody. The only problem is that you could imagine when we're seeing non-emergencies, it does delay care of some other types of emergencies, and then you could see why sometimes the wait times could be kind of long. So that's just the brief start. I think Anne put this together, just kind of the basics, kind of short lists. If you go to urgent care and they think that you have an emergent condition, they will send you to the emergency department. So they're pretty good about, referring appropriately. And they will almost always send you to the emergency department if you have chest pain. So I think that's a pretty good one to put at the top of the list. Shortness of breath could, if you're a young person, might not really be as bad, kind of depends. But usually if you're on the above 50 spectrum, they might also send you to the emergency department. And then of course, any type of like confusion, what we call altered mental status, which would just be something kind of off the baseline of the patient. So normally they walk around and they talk like a normal person and then suddenly they don't wake up. We definitely want to see those guys. A lot of head injuries we'll see because we'll talk about later, but also just kind of the imaging capability that we have versus either like a family practice or an urgent care. We have a lot more imaging capability usually, but not all the time. It depends. And then certainly fainting, because we always worry about that being really a heart cause as a possibility. So fainting we'll often see, but also again depends if you're 20 or if you're 60 or if you have other problems. Vomiting up blood, that's a good one. That one always is going to go to the emergency department pretty much. And then certainly, if you call 911 and they bring you to us, that's a great reason to come to the emergency department. And then I don't know, Anne, if your thought was that Dr. Hennelly would go through this urgent care list, or we can just go.
Doctor, we'll go through the urgent care in just a little bit. That's fine.
Okay. Well, Dr. Hennelly, if you have thoughts in the meantime, please don't worry about breaking in. So I think probably one of the most important things that I would personally tell people to bring is this list of medications and supplements. I get a lot of, well, it's in my chart. Well, that might be true somewhere. It's not always true at my department. Not every single medical office has the same type of charting capabilities or service. So bringing an up-to-date list is going to be the most important, especially if there have been any changes to medications recently. So sometimes it is in the chart and sometimes it is not. Now, you can make a good guess, and I'm sure Dr. Hennelly can also make a good guess on what types of medical conditions you have based on your list of medications. So if I had to prioritize, I would say, please bring the list of medications. But if you're feeling, up to it, it wouldn't be a bad idea to have a list of your medical conditions. Sometimes you can just put them next to the medications, or you could create a separate list and just bring a piece of paper or a list on your phone. Certainly the name of your doctor and pharmacy, you probably know those off the top of your head, but those could always be helpful. And then of course at registration, when you come into any urgent care or emergency room, they'll want to have your health insurance and that kind of thing. Phone sounds totally reasonable because that might be where you're storing your important list of medications. Charger also not unreasonable because sometimes the wait times are long, or you just don't know if you're going to stay. What if you get admitted to the hospital? You might want to have your charger. It seems reasonable. And then definitely patience, which we are also working on here. So yeah, I think this top phrase is pretty important. Like, we don't ever turn anyone away from the emergency department. We will try to see everybody that we can in the most timely fashion that we can. But there are a couple things where you might want to go to one specific location. So if you always go to that same hospital, sure, not unreasonable to go to that same hospital. Sometimes if you go via 911, they might take you to a different hospital, and they might have good reasons for that. Certain hospitals have certain types of designations, like if they think that you're having a stroke, they might take you to a stroke center, which I don't think would be unreasonable. And they might bypass your normal hospital to do that. You can always ask them what's going on if you're being transported, but it's not unreasonable to think if you wanted to go to your hospital, you could always ask, or if you're, headed that way. If you see a specialist that's related to your care, it can be helpful to go to that hospital. For example, if you came to my hospital, but you saw a cardiologist, like a heart doctor, outside of my hospital, I would have to call your cardiologist anyway, which is fine. I'm happy to call them. Usually they get back to me in a timely fashion. And now I'm not saying I talked to your cardiologist specifically, but someone within their group will usually be able to get back to me. Occasionally they can't. And then I will seek my cardiologist's information, which might not be in line with your cardiologist's information, and it just depends. So that would be a reason, maybe if you see a specialist that's related to your care, then you might want to go where they go, which is fine. And maybe that's a discussion you have with them next time you see them, just as an outpatient and kind of a preventive manner. And then I think this one is probably the most important and the least understood generally. And it's, if you had surgery with your doctor in the last month, you're gonna have to go see where they go. If you had back surgery, that's really important that you see your own back surgeon. So I would highly recommend, especially if it's related to your surgery, and that's why I kind of put the 1 month time frame onto there, because 1 month is kind of generally accepted to be well within the post-operative component. It would go there. Now, say you had back surgery and you come in for chest pain and that is totally unrelated. Like I said, we're not going to turn anybody away, and I will try to track down your back surgeon or XYZ surgeon without any problems. But just thoughts about maybe why you would go one place versus another when you're looking at emergency departments. And I think that applies in bigger cities maybe more than Santa Fe, because there aren't as many emergency departments in Santa Fe, generally speaking. I think you skipped the last one, and like bringing kids. Was it? Yeah. Okay. Yeah. No, back one, please. Thank you. Okay. So, sort of on a similar vein, just a quick thing through children, and I think Dr. Hennelly will probably want to have some more say on kids as well. Not all hospitals have pediatric services like inside the hospital. So not every hospital can admit children if they need to, stay overnight for observation, surgery, whatever it is. But all emergency departments can see children. So like, for example, where I went to residency, we did have a specific emergency department for children. And where I work now, we do not, but I still see children. That being said, if I have to admit them, I will transfer them to another location. In Santa Fe, I spoke with Dr. Hennelly briefly this morning. There is no pediatric emergency department. I think the closest one would be in Albuquerque. So it's just good to know, what's available in your area. And I think she'll want to address the pediatricians have after hours hotlines. So do family medicine doctors usually. And so does your regular doctor. Even if you don't see a family medicine doctor, if you see an internal medicine doctor, small word change there, but internal medicine only sees adults. Family sees everybody. They also usually have some type of after hour hotline. And if you're not sure, it's okay to call them. A nurse will triage the call. They usually have a doctor if they need to talk to the doctor some way, somehow. And they'll direct you to an appropriate location. And also a good thing maybe to talk to them, and maybe Dr. Hennelly will talk about this later, in advance. Like, hey, what do you want me to do if I'm not sure, if I think I have an emergency? Okay. We're good.
I'll just add
things to bring children for the emergency department. Oh, Dr. Hennelly.
I was just going to say for Santa Fe in particular, and I understand some of our audience might not be in Santa Fe. Christus St. Vincent's on St. Michael's does have pediatric hospitalists. They don't have pediatric neonatologists. That would be for infants. And they can handle a lot. I'm not actually sure about Presbyterian Hospital. They may not. But if you are not sure and St. Vincent's is the easiest place to go, you can go there and they will evaluate your grandchild or your child. And then if they make the decision to send you to Albuquerque, then they can do that. If you have time, because Albuquerque is an hour drive away, then it would be the Carrie Tingley Children's Hospital in Albuquerque.
Yeah, and that's the experience we have here. I work south of the city, and all of our pediatric hospitals are inside the city. So sometimes people live even further south than where I, work. And so we are the first stop. And that's fine. We can see all ages, just like family medicine doctors. We can see everybody, all ages, and we'll, get them triaged appropriately to wherever they need to go or whatever we need to do. I think that they just wanted to have us go through a few things that, you would contemplate bringing children to the emergency department for, and certainly trouble breathing, sort of like we discussed earlier with other age groups. If anyone looks blue, please go ahead and bring them to the emergency department at any age. Severe pain, sure. High fever. This component about infants is a very specific detail. So I don't know that anyone's going to be here with infants, but if they're under 2 months, and I would even maybe bring it up to 3, any fever is going to need to be evaluated. And if you have an infant, you will have a pediatrician, because they don't actually let you leave the hospital anymore without a pediatrician. So they also will let you know that that is the case if you're called their hotline. And then, of course, we worry about stiff necks with fevers, and then any serious injuries involving the head, neck, spine, any bones sticking out, that kind of thing.
Yeah.
This is just a quick side to a call out to the Poison Control Center. They work across the United States. This is a great phone number to have in your phone. That phone number works all over the US, and they're always available nighttime, daytime, weekends, holidays. Someone will pick up the phone, and same, it's usually a nurse that starts the process, and they have a lot of excellent protocols. I have worked in the Poison Control Center here in Oregon, and it's very interesting. They get lots of different things, and they're very knowledgeable. And actually, I also call them from the emergency department if I'm worried about some type of poisoning or ingestion or something like that. So I always recommend everyone put that phone number into their phone just to have it, just in case. Okay, so this is the meat. So certainly when you go to any emergency department or doctor's office, it's the same. You have to check in and they ask you for that insurance card, or if you don't have one, that's fine. Then you will get triaged. Our emergency department has a sign at registration that requests that you tell them if you are having any really, really severe symptoms, like severe shortness of breath, if you are having chest pain, or if you're having bleeding that is not controlled. So if you think that there's something really bad going on right now, they definitely want you to let them know right at the registration. And you will be triaged according to the complaint. So I see the third bullet is weight. A lot of the time it is weight. Sometimes it's not weight. For example, if you have chest pain, they will get an EKG on you, which is that electrocardiogram where they look at the electrical component of your heart within 10 minutes. So you'll get an EKG. That does not mean you'll see a doctor within 10 minutes. It might, but it might not. But so there are certain things, especially like stroke-like symptoms as well. Ooh, here we go. That will be, triaged appropriately because some things are very time sensitive. Well, after triage, sometimes they'll put you back into the lobby. And that is very common these days. I'm sure it happens the same way in New Mexico as it does in Oregon. We have not enough beds to see everybody right now. Not enough beds in the hospital, not enough beds in the state, not enough beds anywhere unfortunately to see everybody immediately. So sometimes you will wait. Of course, if while you're waiting, something happens, you're getting worse, things are going the wrong direction, you start bleeding uncontrollably, they want to know that again in the meantime. And then you will get some type of room. I'm not sure if anyone has been to the emergency department lately, but rooms are a loose term right now, basically since COVID. So there are a lot of hallway beds. So a room or a bed, a location where you will be seen. And then usually the nurse will start off again, so they'll get a new set of vital signs, and then they might draw some blood, or they might have some things, that they can initiate based on the chief complaint, which is, the chief complaint is what we call what's wrong, what you're describing is wrong with you. And then you will see someone else. So me, or another doctor, or an APP is one of those NPs or PAs. Those are other people that help us staff the emergency department. At that point, when they're leaving your space, your room, that's a point where I would want you to understand what we're doing. So if the doctor or the APP is leaving and you're not sure what's happening, like, wait, what did we decide? What are we doing? Are we not doing? I'm not sure. I don't know. That would be a great point to put a pause and say, I don't actually know what's going on. Like, what are we expecting here? But I would say from when I see the patient, very frequently it can be up, like an average visit would be like 3 hours from when I see you. So not when you check in, not when you get triaged, but from when I see you, just to kind of put out some general expectations. But it also depends on what you're there for. So I alluded to all of these different people. So they're MDs and DOs. Those are both medical doctors. Lots of emergency departments will staff only with emergency medicine trained doctors. That's like me. I'm a board certified emergency medicine doctor. But some locations don't have enough board certified emergency medicine doctors. And so they'll use other kinds of doctors, like family medicine sometimes, internal medicine sometimes. But I think that's getting less and less common. It's more common if you live in a very small town, out in the wilderness. PAs and NPs. So that's what we were talking about. Those are nurse practitioners that went through nursing school and then additional schooling, or physician's assistants that also went through additional schooling after college to get to where they are. And most of them can see a lot of patients, but they don't necessarily see all the patients. Sometimes they only see certain types of patients, and that's decided in each emergency department how they decide. And then, of course, everybody knows we need nurses to do the real work. And then we have at least in the emergency department, we have a lot of technicians and like medical assistants that help us do like everything else in between. So they can take vital signs, they can do some splinting if you broke a bone, they help clean, they help us stock the rooms. They help us make phone calls to find the other doctors that we need. They'll walk patients, anything. They're the first line of defense. If you're in the room and you have a little button to call, they'll say, "Hey, what's going on?" And they'll pop in to help you or find the right person. Yes. Acuity. So this is a number from 1 to 5. It's assigned by the triage nurse. It depends on a lot of things, sometimes including the nurse. So your age, vital signs, what you're coming in for. Are you having chest pain? Are you having abdominal pain? Does your toe hurt? You won't see this number, but this number explains why some people might go back to the back, like out of the lobby before you. And it's just because we don't have enough stuff for all the people. We don't have enough staff. We don't have enough beds. We don't have enough anything, unfortunately, right now for everyone. So a level 1, you probably wouldn't see a level 1, or you'll see it as a big mess. Something will happen in the lobby that's kind of, very exciting and some may potentially catastrophic, or they'll come in via ambulance because that's kind of a imminent danger. And then lots of people will fall into this 2 and 3 category, and then a few people will fall into this 4 and 5 category. Why do I have to wait? I think this is a good question. And I sort of alluded to the fact that we simply don't have enough of everything right now in most places. But one reason could be the acuity level. There might be a lot of really sick people that suddenly show up in the back via the ambulance and you just don't see them. It depends on the time of day. When you're leaving, say you get admitted to the hospital. Well, it turns out when you leave the hospital, most of that happens during the daytime. So if our hospital is running at capacity, which just means all the beds are full, the discharges from the admission units will not happen until the daytime. So earliest would be like 10 o'clock. Sometimes they can be as late as 5 o'clock. But so sometimes there are just not any beds, and then a bunch of beds open up, and then all of a sudden there's all a space to see everybody out. And then we say, yay, and we get to everybody. Some labs and tests are very slow. Some of you might have had an MRI before. The MRI itself can take up to an hour, just the test. So imagine that someone's in the MRI, and then you need an MRI, and then someone else was already scheduled for an MRI. You could see why things might kind of pile up on wait times there. And then not all hospitals have all resources. We sort of alluded to that with some things about kids, but not every hospital has an MRI. Not every hospital has every consultant. And not every hospital just has everything. So those are all reasons you might have to wait. Oh, there you go. In short, there are too few resources for too many people. I put this staffing as just my average staffing. So I on average staff 10 rooms. But for example, overnight, our staffing model goes down to 1 doctor at 3 in the morning. So I have the entire emergency department to myself, which could be up to 27 beds. So that could be 27 people that I'm seeing simultaneously in some way, shape, or form. So you could imagine that also causes wait times, although everyone, didn't come in at the same time. So there might not be a severe delay. But sometimes I'll get called out of rooms. So that obviously disrupts the capacity. And then, of course, nurse staffing is dependent. You might have heard, hey, buddy, that there's some nursing changes going on lately, and that is true, at least in Oregon. There's a new law going into effect that the nurses can only staff certain amounts of beds for patient safety reasons, trying to not get overstretched and make sure they can attend to everybody appropriately. So occasionally we don't have enough nurses, where the nurses have to. Hi.
I think, Lindsay, I think this kind of goes back to also considering about the time of day if you're having emergencies. Obviously, sometimes emergencies happen immediately. You fall off a ladder or something happens. But if you have a situation that seems to be growing and getting worse, as Dr. Ballard says, At nighttime, the staffing is lower, the technicians and the equipment may not be available. So if you're thinking about having to go to the emergency room, the emergency department, then you really might want to consider going really during the day. It's going to be much more efficient. Friday night on Labor Day weekend is going to be really an issue. And I think that that is one of those things when you're really considering what to do is to consider the time that you have and consider what resources might be available at the hospital itself. And Ree, did you have a comment on that too?
Just to make a comment, if you know
Volume up.
something, oh,
There we go.
can you hear me now?
That's better. Yeah, thank you.
Better. Okay. Just to make a comment that if you know that this is chest pain that needs to be checked out, please do not wait until 8 a.m. to come. That is true if you know that it's something that can wait. When I rotated through emergency departments, I had patients who they came in with a rash and I went in to see them. And they've had the rash for 5 years, wasn't getting worse. They didn't see any doctor about it. And you want to know what the rash was? It was acne. And so we sent them across the street to the clinic to set up an appointment. I had a young woman come in because she didn't know that what she had was a hemorrhoid, and that was scary. And also, we have to keep in mind that our actions that might fill up the emergency department might also make it so that our loved ones next time don't get, seen as quickly as we would like them to. So anyway, if you know that it's really an emergency, please do not wait. But yeah, I think part of this talk is education around how do we use the limited resources that we have, especially more limited since 2020 and the COVID, where everything's gotten more scarce. If anybody wants, something fun to do at night, you can watch The Pit on HBO, which is actually a really great representation of what's happening in the emergency departments, or so I've heard from emergency department physicians. It really illustrates the current struggle and the wonderful job that they do despite the limited resources. I have no financial interest in HBO. All right. So I think we're on to urgent care.
I think Lindsay just has, I think talking about the resources that when you go to the emergency department, like you said, you're going to see the RN, you're going to see the receptionist, you're going to see the RN, you're going to see a few people, but there are all these, it's just like a movie. When you run the credits, there's one star on the screen and there's 25 to 45 people behind the scenes. So there's a tremendous amount of resources going into keeping the emergency department going and providing services to you. So just be aware of that. And one of the things I think both Dr. Hennelly and Dr. Ballard can easily say is have some compassion for your medical professionals because they are really working, like Lindsay says, sometimes she may be running the ED by herself at 3:00 in the morning with 25 beds. So that is very stressful. Have some patience, but also be assertive. You have rights as well. One of the things we love to tell people is to be assertive. That's not aggressive. But be sure to ask your questions. Be sure to answer questions. If you have questions, just ask the people and they'll find out for you.
Just a few more. Right. So this is alluding to the consultants, those other doctors that I can reach that sometimes urgent care cannot reach. So occasionally it's really important that I need to talk to somebody else, an expert in their field. And there are lots of those around. You guys are all probably familiar with surgeons. Sometimes I talk to an internal medicine doctor or a family medicine doctor. I talk to the heart doctor a lot. I also talk to our orthopedists, bone doctors, OB-GYN, pediatrics, just really anything that's going to be end up being pertinent to your particular case. So they also slow down the emergency department sometimes because when I call them, they're at their work, they're at their job. Sometimes they're in cases or procedures or things like that. And a lot of the times they take the time to speak to me, even though they're in surgery. So if it's safe, of course. But so those are things that I have access to that the urgent care doesn't always have access to. And that might be one reason they decide to send you to see me instead of staying there. They just might not have access to some of those people that they think you might need. But usually I can find almost everyone. It just might take some time.
So I think now what we're going to do is kind of switch now because, and Dr. Hennelly is going to talk about urgent care and also your primary care physician, other levels of care and what they're able to offer. And as she discussed earlier, things that might be going on for a period of time might be able to be covered elsewhere than the emergency department, which might then free up resources for people coming to the emergency department that need more urgent care. So
Thank you, Anne. Thanks, Dr. Ballard, for the great presentation. And thank you to Villages of Santa Fe and the Santa Fe Public Library for having me. So this is a quick Google search when you search for urgent care in Santa Fe. There are a number of them, and they should all have hours and phone number listed. Usually they're not going to be open 24 hours a day like an emergency department, but they will be open for the most part until 7, 8, 9 p.m. Sometimes. Sometimes you can take an appointment. Oftentimes you can just walk in. One of the things that you might want to do is call ahead always and see if they take your insurance and see what fees might be associated with the visit. They might not always be able to tell you because it depends what you're coming in for. But you might want to just, ask if they have kind of a summary for them. So this is the same slide as Dr. Ballard covered before. I think a good use of an urgent care is going to be in the second column. So common illnesses like a urinary tract infection. You have really bad allergies. Santa Fe has been hit by the wind in the past week, and we have a lot of people with allergies that are feeling pretty crummy. That's a good place to go. If you have nausea, sore throat, sinus conditions, earaches, headaches, particularly if the headaches are something that you've had previously and you know that this is your headache, it's just worse than before, that's a good reason to go to the urgent care. On the other hand, just specifically for headache, if it's a headache that you have never had before, it's the worst headache of your lifetime, particularly if it started suddenly, or if it was so bad that it woke you up from sleep, that would be a reason to go to the emergency department because you might need head imaging, right? That might be more a symptom of a brain bleed, for example. Minor injuries can often be taken care of at an urgent care, such as broken bones, fractures, certainly sprains and strains, which you might not know at the time, and you might need an x-ray to tell apart a sprain versus a fracture. So one of the things that I would do calling the urgent care if I was worried about whether I had broken a bone is ask if they have x-ray on site. Some do, some do not. Some can kind of stabilize the joint and just say, listen, I think you need to follow up with the orthopedist tomorrow or later this week, and here's the phone number, here's a referral for them. And sometimes if there's a question, they might send you to the emergency department, particularly if they have a high suspicion of a fracture that might need to be set, for example. And you would want to have that. Certain ones need to be done sooner. Other ones can really be delayed for a few days or even up to 2 weeks without any issues. Cuts, burns, that will depend on on who's there. So again, I would call ahead, because depending on who's staffing, they may or may not be comfortable sewing up certain cuts on certain parts of the body. And you might also want to describe if your burn is just on your wrist or if it's, like a full chemical burn. And you might save yourself a trip to the emergency or to the urgent care if you let them know and they say, you know what, I think you should go to the emergency department for that. Vaccinations would be something I would also call urgent cares for. Some of them have, some of them don't. They will all have tetanus because, again, remember, you want to be up to date with your tetanus shot. And if you're not up to date with your tetanus shot when you've had a cut, they want to give that to you. So they will all have that. Bug bites, other non-emergent skin conditions would be fine for an urgent care. Injuries to the neck, back, shoulder, elbow, hand, hip, knee, ankle, or foot. If you're generally fine, if it just hurts really bad, urgent care might be the best place to go first. But if it really seems major, most people kind of have a sense of when they need to actually get to the emergency department for this. If you have a bone sticking out of your ankle, please go to the emergency department. And then sports-related injuries, including head injuries and concussions. So sometimes you don't actually know if imaging is necessary, and urgent care would be able to kind of help you decide whether or not you need to go to the emergency department. If somebody has lost consciousness, if somebody is really acting abnormal, I would probably just skip the urgent care and go straight to the emergency department. And then most urgent cares are going to have, well, I would say all urgent cares are going to have rapid flu, rapid COVID, rapid RSV for the little ones. And obviously, do not wait for any of these if you need immediate medical attention. I'm going to stay on this slide for just a second to say top left under reasons to go to the emergency department is chest pain. A note about that is that we do know that chest pain is the most common presentation for a heart attack, but so can be shortness of breath. And in women, heart attacks can also present atypically as indigestion or upper stomach pain. So just something to keep in mind. It might be indigestion. We live in the land of green chili and red chili. But if it's something that you usually don't get, it might be worth checking things out, particularly if you already have heart conditions.
Well, I also think, I know if you go to urgent care and they determine you've got shortness of breath due to a heart issue, they're going to call the ambulance and you're off to the emergency department. So that's always that's going to happen. They're not going to say, well, we can't service you. They're going to help you get into the hospital.
The list of things to bring to an urgent care is very similar to the list of things to bring to the emergency department. This is essentially the things that you would take to somebody who doesn't already know your medical issues. So a list of medications, supplements, a photo is so helpful. Oftentimes there might be combination medications, and if we don't know that you're on both, because who's going to remember the long name of any medication? It is sometimes nice to have a photo of the actual bottles with the dosages, list of your medical conditions again, name of your doctor and pharmacy. Every urgent care is going to ask you for your health insurance first. Vaccination cards, I don't know if it's necessarily something that you need if you sprained your ankle, but again, they might want to see when your last tetanus shot was. Phone, charger, long charger you can stick to the wall would be great. We have been asked for chargers. We don't have chargers for patients, although that might be a redesign in the future when urgent cares have a lot of money. And again, patients, urgent cares will triage you the same way that emergency departments will triage. And so some people might go in before you do and just trust that they have a good reason for it. So again, for an urgent care, I would recommend calling first, seeing who's working that shift, seeing if you can check in online, seeing if they can take care of what you have during that particular shift with their particular staff that day. If you think you might need an x-ray, saying, do you have x-ray? You might not need an x-ray by the time, like they might have an x-ray and then you get evaluated, you might not need an x-ray, and that's okay. That's probably even better. Ask if they have the capability to do splinting in the case of, an arm or leg injury. Do they have rapid tests? Are they out? They might usually have it, but do they currently that day have the test that you think you might need? Again, you don't have to do these things, but it might save you a couple of hours trying to get to the right place. Once you get there, you'll be asked to fill out paperwork. You'll be asked to give your health insurance information. And then based on what you're there for, the nurse will usually kind of assign you a similar acuity level. And then you wait. One of the nice things, one of the not nice things about waiting is that you might be in the room with other sick people. And so that might be an opportunity, if you want to wear a mask, to wear a mask so that you don't go to the urgent care and then come back with something that you didn't go in with. Then at some point you will be called. A medical assistant or a nurse will take you to a room. They'll take your vital signs. They might do a swab or collect some urine beforehand so that by the time the provider comes in, whether it's a physician assistant, nurse practitioner, MD, or DO, they already have some of the pertinent information. And then you will either receive a prescription, referral, instructions about follow-up care. You might receive reassurance. That is probably the best situation, right? I think I have I think I have strep throat. I'm not sure if I need antibiotics. Wow, great. I don't have strep throat. I don't need to go through the hassle of antibiotics. And then at that point, if they think that you need to go to the hospital, it was not a waste of your time. They did the first initial review and it's good. Now you can say, okay, I know the emergency department might be a wait, but it is worthwhile. And yes, I am going to the hospital with more confirmation. Okay. So in urgent care, there are also going to be a lot of people helping. So MDs and DOs, whether family medicine, internal medicine, emergency medicine, often staff urgent cares. Sometimes there are pediatricians if it's a specific pediatric urgent care. Then there are the APPs, which we sort of say are the physician assistants and the nurse practitioners. Just because I don't think a lot of people are aware, there are differences in training. So MDs and DOs complete medical school and residency together often, right? Before, like years and years ago, DOs did not complete the same residencies and fellowships, and now they do. Physician assistants, which came out of, I think, World War something, where a lot of techs were coming back with the doctors knowing a lot, and we said, well, we need you to be part of this medical system. On average, they complete a master's program of about 27 months, or a little bit over 2 years of medical education, which includes 2,000 hours of clinical rotations, again, on average. Nurse practitioners are registered nurses that have completed additional training. Some of the training is all online, some of the training is all in person, and there's variable hours. So that training is not as standardized as PAs or MDs or DOs training. Nurses will be the ones who will administer treatments, dress wounds, etc., certified medical assistants, help with taking vital signs. And then if there's x-ray capability on site, you'll have the imaging technician. A little note, so just to kind of give everybody a sense, both APPs and physicians require undergraduate degree. And then on top of that, medical school is another 4 years. And then family medicine is probably the shortest residency. It's 3 years. Emergency medicine might be 3, 4, 5 years, depending if you do a fellowship on top of that. Internal medicine is 4 years, 3 or 4 years. Dr. Ballard, now I forget. And then, so if you compare that to a nurse practitioner's education, they do get the undergraduate degree, and then their training subsequent to that is variable. So it might be anywhere from 1.5 to 3 years before they're able to practice independently and be hired independently by an emergency department, an urgent care, a regular clinic. And so that's sort of reaching the level somewhere of a second-year medical student, third-year medical student, maybe fourth-year medical student. And again, this is just illustrating the number of hours you can expect, the number of clinical hands-on training hours that you can expect your attending physician to have in the blue, over 21,000 compared to a resident, 15,000 compared to a fourth-year medical student, 6,000, a physician assistant about 2,000, and then to the right, a nurse practitioner at the minimum should have about 500. So as a family physician myself, I included here a third option outside of emergency care and urgent care for urgent issues. So your primary care office is a great place to call as well. Hopefully everybody has a primary care doctor. That's becoming hard to find, and particularly so in New Mexico, so I do acknowledge that. Some of the benefits of going to your primary care office would be that you know your physician knows you, your medical issues and medications are already in the system, you have familiarity with the location, how to get around the facility, maybe you know the medical assistants and the nurses, and you know what the billing structure is going to be for a visit. Continuity is going to be available if somebody says, you know what, let's do this for a couple of days and then let me put you in and I'll see you on the third day to see how you're doing. That's going to be more available at your primary care office as opposed to somewhere like an urgent care where they might have rotating staff and different schedules, so they might not be able to have you see the same person. And I think from Dr. Ballard, I don't really have a sense that urgent cares and certainly not emergency departments have people follow up with them, right? And then instead of getting to your primary care doctor's office 3 days after your emergency department visit and nobody having the records yet, which there's a lot of faxes that might be missed on either side, we're always working to improve those. If you go to your primary care office from the start, the record of your illness and the tests that were done and your vital signs at that time will already be in your chart. Cost is often lower because it would probably be billed just as a regular office visit. Some cons is that there might not be same-day availability, and there might not be same-day availability with your doctor. So when you call, you can say, hey, I'm so-and-so's patient. I'd like to be seen today if possible because I have an urgent issue today. And you can explain what that is. If they say, I'm sorry, so-and-so, doesn't have any availability today, I do encourage you to say, okay, that's all right. Is there anybody who can see me today? Because they, depending on their experience, the telephone triage staff might not offer you automatically. They might assume you want to see your doctor, but you can just say, is there anybody who can see me today? I really think this needs to be seen. The other con is that you might come and your doctor might say, you know what, I actually think you do need to go to the emergency department. So that's an extra step, but we do want to make sure that you are taken care of appropriately. Whenever you establish care at a new primary care office or the next time you go in, some questions you might want to ask is, as we were alluding to before, where should I go in case of an emergency? Some physicians also work as hospitalists. Some outpatient physicians also work as hospitalists, meaning that if they see you in clinic, they would also want to see you in the hospital, or they have a practice that they will want you to see. Maybe they're affiliated with Christus more than Presbyterian or vice versa. So those would be questions to ask. Maybe they have a track record of getting records a lot easier from one institution than another. Maybe they know that in your case, you have certain surgeons or cardiologists that, and they want you to see, to stay in that same system, so they recommend. So that would be something to clarify. Also clarify, do you have sick visit appointments, and how do I access these? Virtually 98% of all primary care offices are going to have these secret visits that are saved for people who woke up vomiting and can't stop vomiting, or woke up and realized they have a raging urinary tract infection, or think that they have COVID or whatever, the cat exposure. Those are sick same-day visits, and you can always call. The earlier in the morning you call, whether your office opens at 7 or 8 or 9 o'clock in the morning, the better chance that you will be able to snag one of those. But those should be available at every office, and I don't think people know that very much. So that would be something to know about. And then again, you might pick up over time, or you might ask, are there x-rays at the primary care office? Some primary care offices do have x-rays, and they can just send you down the hall, and you can get that done same day after you.
Marie, I thought it was really good. Recently, I called my primary care physician, not knowing if they could get me in, but they could do a telemedicine call, which was a big help.
Yeah, absolutely. Right. Splinting, some doctors can, some doctors can't, some clinics can, some clinics can't, depending on whether they have the correct supplies. Laceration repair can often be done in clinic, but again, you have to just ask, would that doctor, would that provider be able to do that if this is what I think I have? Because the gash in my arm is actually really, notable. Can you do lab draws? How quickly would the labs come back? Do you have currently in stock rapid flu, COVID, RSV, strep swabs? Would you be able to tell if I have a UTI? Do you have UTI testing? A lot of places will have limited amounts of antibiotics if you need IV or intramuscular antibiotics. And some places also have IV fluid, for example, if you're feeling really dehydrated. So here's our slide again. I added on the right side a column of things that family medicine clinics and many internal medicine clinics and pediatrics clinics can do. Again, so I would say the first stop would be a family medicine clinic if you have common illnesses, sore throat, headaches, minor injuries. We can help tell whether or not it might be a sprain, or maybe tell you whether or not you think you might need an x-ray, save you the cost of an emergency department visit by sending you to the x-ray office, down the street. It's not all going to happen in the same coordinated, quick way, relatively quick way, right? Quick way that emergency departments do it, but it can be a cost saver. Absolutely. Vaccines, bug bites, skin conditions, fractures. If you know that it's definitely broken and know that it definitely needs to be set, just go to the urgent care or emergency department. And I would say the same with head injuries and concussions. A reminder that preventive care really will keep you out of all of these offices. When issues are not urgent, for example, acne, constipation, anything that you've had for more than 2 or 3 weeks, visiting your primary care provider is probably the most cost-effective route to address these. I will put a plug in here for vaccines. If anybody is over 60, get your RSV vaccine. If anybody hasn't gotten their flu shot or COVID shot, usually by March, the season is over, but we are still seeing a lot of COVID and flu. It is worth it still to get your flu and COVID shot, at least in New Mexico, at this time. one note about eyes, this is sort of a carve out, I would say, from everything else we've talked about. Eyes are very delicate, right? If you have a red and painful eye, make sure you're seen immediately. Okay, so if it's just red and not painful, if it's just painful and not red, that's it. But if it's red and painful, those are your keywords. And you make sure that even if the front desk doesn't know, you say, can you please let the doctor know that I have a red and painful eye and I think I need to be seen today. Importantly, not all places have the type of equipment that's needed to evaluate what could be a corneal abrasion, a corneal ulcer, or uveitis that could indicate something a little bit worse. The emergency departments, probably in UNM, would definitely have an ophthalmologist on call, definitely UNM. I do not know if the emergency departments in Santa Fe have the ability to have ophthalmology come in and see you in the emergency department. Emergency department physicians can do a lot of the evaluation, so it's probably worth it to go in anyway. But if it's during the day, between 9 to 3, because, offices close at 4 and 5, just call the ophthalmologist office directly, and their front desk staff should know that if you say I have a red and painful eye that I understand I need to be seen today for, they will usually talk to the doctor and try to get you in. So that for that, I would do, directly Botwin Eye Group or Eye Associates. Oh, can you go back briefly? Okay, most other eye emergencies, for example, if you have sudden vision loss, double vision, those can be potentially reflective of what's going on neurologically, and those should be seen at an emergency department. The other thing I didn't put here is floaters or flashes could be signs of retinal detachment. And again, I would go to the emergency department unless you can get in to see ophthalmology that same day. Again, if something's been happening for days to weeks, just schedule an appointment with the ophthalmologist.
So we've had a lot of information. I just want to talk to everybody about calling 911. I deal with the villages, and I get calls from people all the time saying, my spouse is on the floor. What do I do? And I say, well, call 911. Well, he doesn't want me to call 911. Well, at that point, you're the adult. And if there's an emergency, somebody's in a bad situation, they're not breathing or they are having difficulty breathing, they can't get off the floor. Call 911. People are nervous about doing this, but I have to say, it's better to be safe than sorry. Paramedics can also begin delivering life-saving treatment on the way to the hospital. But not only that, they are wonderful people. They are just the nicest people you are going to meet in the world. And first of all, if you call 911, they're going to come and evaluate your situation. They're going to give you the opportunity and say, they will give you an opinion about whether you should go to the hospital or not. It is your decision whether to do that or not. But it's fine to do it. And I would think it's really, really wonderful. The other time when I really emphasize about calling 911 or going to the hospital, if the emergency department, if you have a traumatic brain injury, if you do fall and hit your head, if you are unconscious or you have blurred vision or speech issue, you're confused, please go to the emergency department. They will evaluate you, and then you can call 911. I would anticipate that you should call 911 at that point so that you can be evaluated, because TBIs, traumatic brain injuries, are something that nobody can diagnose by themselves. It really is a medical diagnosis, and it can kill you. So we really want you to, feel safe about calling 911. So we have some questions, and what I'm going to do is I'm going to stop our share. And hold on a minute here. And I'll unmute people. Hold on a second. Here we go. tools. You can unmute yourself. We do have some questions, so I'm going to go ahead and read these questions. And if Lindsay and Dr. Hennelly can answer, what's the best jargon to use within the medical? Oh, they're talking about ED versus ER. So I think you can use either one, right, Lynn?
Yes, I think either one is fine. ER is kind of reflective of the past where there was only a small room with like a couple of beds and some curtains, and now we're a technical department, but we will not fault you for either terminology.
That you won't get kicked out if it's ER. All right, great. Somebody wanted to know where the closest stroke center is in Santa Fe. You will be transported to UNM actually. If you go to St. Vincent's or Presbyterian, they will, if you're having a stroke, they'll probably medevac you to UNM. I just had that recently happen to a friend of mine. And we had a question about insurance, but that's not something we can answer here about Medicare. I think the best thing, if you have a Medicare, you can call Medicare. Of course, right now, trying to get a hold of them is also almost impossible. But if you have Medicare, either original Medicare or Medicare Advantage, you probably have a number, whether it's United Healthcare or Humana or whatever it is, Blue Cross Blue Shield. You can actually call them in advance and find out what's covered. Recently, I tried to get an explanation of benefits, and basically I was told you have to tell me exactly what you want to do before I can tell you what is covered. So you really have to know about that. In another question, are tests at urgent care repeated at the ED if they send you to the ED? Lindsay?
It depends on the test. So sometimes I can see the results. Like if you got a flu test and they sent you because you had worsening shortness of breath, I can see this flu test that it's negative or positive or whatnot, then I will not repeat the test. Some tests just have to be repeated. It's kind of a thing where you're trying to follow what's happening. So you may have a repeat test because of that. And then sometimes we can't see the testing. And certain hospitals have different protocols. For example, kind of a COVID remnant, if you're there for some type of respiratory problem and you're being admitted and we can't see your COVID test, we're going to have to get a new one because that's just what they require with the admission to the hospital. But typically, we will try not to repeat tests that are, unnecessary.
It is very reasonable if you are being sent from an urgent care or a primary care office.
A little louder.
It is very reasonable if you're being sent from a primary care urgent care office to request that the note be sent along with you or that a summary be sent along with you, which will often take a few more minutes. So if you don't have a few more minutes, you're not going to wait for that. But if the pace of whatever's going on is on the less urgent side, then that's absolutely reasonable for you to say, you know what, is it okay if I just sit out here for a few minutes and can you give me something to bring to the emergency department that they can see what your vitals were, what the tests were, what the thought process was of sending you.
I also think that one of the problems we have is certain medical organizations don't talk to each other well. They don't run well with each other. They don't, they kind of keep in their corner. So it's really up to you to have your information and your testing, and if you have any scans or anything like that, and you have to go to another complete different group. I keep that with me and I take that with me. So I literally can hand that to the doctor and say, here's the tests that I've had. Here are the scans that I've had. And that way we don't have to wait for them to see if we can't get them from that group. The information is right, really does solve a lot of problems. The other thing is writing down your symptoms, because sometimes when you go, oh, I'm just stressed, it's at night or something's really serious. But if you can stop and write down the symptoms, so along with your medications, you can give the doctor kind of the sequence of what's happened, then that might be a big help, because it might be something that you honestly forget. And I know from Dr. Ballard and Marie also that you're not clairvoyant.
I
And
wish we were.
Yes, you wish you could just like, take the information out, but it's really important for you to translate that information and give that information to your doctor, including like things like supplements. People take a lot of supplements and they may be interacting with things. We had a question, some urgent care facilities are offering memberships to get ahead of the lines, boutique services. What are your thoughts on that? We have concierge doctors now. Yeah.
I think that was an inevitability of living in a capitalist system. Their ethics behind seeing somebody with a stubbed toe overseeing somebody who's like bleeding profusely from their head. So well, I'll just leave it at that. It is, I think that's not going away, and also there's some issues with it, just from an ethical standpoint.
Yeah, I think that
can, that's
yeah.
know, that's our life, that's our reality right now. You can and you have.
I think if you maintain a good relationship with your primary care physician, I think that's really important because they can open up a lot of doors for you, because it's always about who somebody knows. They're able to possibly get into a group or get a doctor to return a call quicker than you could just by calling. Let's see. So if you'd like to unmute yourself and ask some questions, that would be great. See, we have, okay. So we really appreciate your coming. I hope you got a lot out of what's going on today. This recording will be up online tomorrow afternoon at Village. I'll go ahead and put our URL in there. It's Villages of Santa Fe. It'll be in the blogs. There we go. And upcoming in April, we do have a program on advanced healthcare directives and also end-of-life options New Mexico. Those are specific to New Mexico, but obviously advanced health directives are available in every state. Every state's going to have slightly different ideas, but you're welcome to attend. I think everybody will get a lot of it. And we want to thank both Dr. Hennelly and Dr. Ballard and Mr. Lucas over here for having us and giving us great information. Thank you.
Thank you.
Bye.